Okay, good evening, friends. One second, I will just set up my YouTube so that I can see your message. Okay, good evening, everybody. Good evening, Ruchira. Good evening, Gayatri, Murugan, Gargi, Injecting Dentistry. Good evening, everybody. I am Dr. Himani Joshi, your original guru for oral and maxillofacial surgery. Just a little brief about myself. I've done my BDS from Government Dental College and Hospital, Ahmedabad. After that, I did my 1 year of preparation. I took a drop, and with a good All India rank, I landed up in Maulana Azad Institute of Dental Sciences. Did my post graduation in oral maxillofacial surgery from MAMC. It's a great learning experience. It's a great college. Following that, again, we were on roads and waited for a year, gave multiple exams, and finally cracked the senior residency exam of Lady Hardinge Medical College. I was there for 1 year. I kept writing these books for entrance examinations like current dental examinations and review of examinations in dentistry, the red book which you sometimes read. And then I was also selected as an SR at AIMS, Delhi, where I worked for 4 years. Okay, I worked there as a SR and as a pool officer, which was post SR kind of junior faculty. And then I resigned. Between PG and BDS, I was a JR also at AIMS Delhi. So during this journey of JR-ship to BDS to MDS to SR-ship, I was fortunate to learn under some great teachers, some great surgeons, some disciplined people, and whatever little bit I have learned from them, today I am trying to put that across to all of you. Hope you enjoy the class. Best book for orthodontic surgery, Akash. You're not supposed to read any textbooks here if you are a BDS student. Okay, you're not supposed to read. Although for orthodontic surgery is given great in Fonseca, in Renike. Renike is a very good book. Even in Kadimani, it is very good. But you're not supposed to read any textbooks. You're supposed to read only the syllabus, little bit syllabus, which is expected to be asked from you. Okay. So in this live class, we will begin with understanding orthodontic surgery. In the course of the lecture, I'm going to show you a lot of videos because orthodontic surgery is something जो हम usually BDS में we don't see very often. Okay, we see fractures, we even do IMFs, we see pathologies, we see infections, exodontia. Orthodontic surgeries, maybe sometimes you're fortunate if you're going to the OT or seeing the surgery, but purposefully I've taken this difficult topic in the start so that the fear of oral surgery goes away. And in the journey of this 1.5 hour lecture, I'm going to show you certain videos also so that concepts become clear. In the end, we are going to solve all the previous year questions, last 10-year questions from orthodontic surgery that have been asked in NEET and INI, so that the twisting of concepts and the clinical application of concepts is clear in your mind. All right. And tomorrow, before we begin the live class again, we will have a small quiz which is called an RRQ, a rapid revision quiz, wherein the same topic will be asked to you in a quiz format. So in multiple ways, we will try and revise the same topic again and again and again. All right, thank you, Ruhani. Yes, Komal, I just heard about the Ahmedabad plane crash. I was there 4 days back, sitting with the students of GDCH Ahmedabad, sitting with my colleague from AIMS, who is now a assistant professor there, and it is very, very troubling to hear this news that the plane has crashed into the hostel. But let's not digress. Let's not get a little too emotional over this news, and let's do what best we can do in this next hour. Yes, DBMCI notes are more than enough, Sami, for oral surgery. Any subject, the DBMCI notes are more than enough to crack any entrance exam for MDS in India. All right, so let us begin. A lot of you are here. So let's begin the class with orthodontic surgery. All right, so what is ortho? We've all studied orthodontics and orthopedics. Can somebody quickly tell me what is ortho? I'm waiting for your comments in the comment box here. What is the meaning of ortho? Orthognathic, orthodontics, orthopedics. How to study surgery? It's not a topic for now, beta. We are studying oral surgery. Bone. Align. Gaurav, you are absolutely correct. The meaning of orthos is straight or aligned. Alright? Ortho means aligned or straight. And gnathos, the meaning of gnathos is jaw. Alright? So any surgery which is done to align the jaws is known as orthognathic surgery. Okay? Now, why do we need to align the jaws? The alignment of jaws is needed for good function primarily and good aesthetics. Okay? So, क्यों कर रहे हैं? Why are we doing orthognathic surgery? We are doing orthognathic surgery. We can do everything with orthodontics also, but everything has a limit. Orthognathic surgery also has a limit. If I want my mandible to go ahead 20 millimeters, I can't do it. So there is a limit to everything. Okay. Similarly, orthognathic surgery is when the orthodontic limits are over. When you can't manage the function and the aesthetics with tooth movement alone, with orthodontics alone, then you step ahead, you move the jaw along with moving the bone. And what are the functions that will improve or that we want to improve? Airway, speech, and looks. Airway, speech, and looks. Aesthetics is looks, airway, and speech. So to correct the function or to correct the aesthetics, when we move the jaws to align them correctly, it is known as orthognathic surgery. Now there is some confusion among students that they always feel that an angles class 1 occlusion is the right occlusion. Okay? No, that is not the purpose. A good cusp fossa relationship is the right occlusion. Okay? Now when I say that, there are three kinds of faces that I see. Okay, now we'll talk about the skeletal discrepancies. मैं skeletal बात करूंगी, मैं teeth की बात कम करूंगी. I'm going to talk more about the jaws, the maxilla and mandible, less about the teeth. Okay, and here to explain you, I have two friends here. They are called Shiv Ram. So this is Shiv, who is white, and this is Ram, who is dark, and we'll be taking their help in between whenever we want to understand things better. All right. So if you see these three images, this middle face is a straight profile. Okay, orthognathic face. It's an orthognathic face. Why? Because the upper third of face, the frontal bone and till this region, okay, upper third of face, the middle third of face, which is nose to maxilla, okay, this region, the middle third of face, and the lower third of face, which is this lip to chin region. All the 3/3 of face, 1/3, 1/3, 1/3, these three are aligned. So this is a straight profile which we call as an orthognathic profile. Okay. However, a lot of times the profile can be convex. Okay. Remember the 9th standard, 10th standard physics, convex lens and concave lens, right? Just like that, lot of times the facial profile can be convex. That means a skeletal class 2. Skeletal, okay, I'm not talking about the dental class 2 which can be corrected with orthodontics. I'm talking about a skeletal class 2. Or it can be a concave profile which comes with a skeletal class 3. Okay, a skeletal class 3 causing a concave profile. Now understand this. A skeletal class 2 can be because of the maxillary excess, when the maxilla is too forward, or it can be because of the mandibular retrusion or retromandibularism, right? Are you all understanding what I'm saying? Are you all with me? Are you all understanding what I'm saying? Just give me a thumbs up अगर आप सबको समझ में आ रहा है. I'm purposefully not trying to speak a lot in Hindi because a lot of South Indian students here will be unhappy. Are you all understanding what I'm saying? Just give me a thumbs up there on the chat box अगर सबको समझ में आ रहा है मैं क्या बोल रही हूँ. Are you all trying to understand? I mean, able to understand everything? Okay, so Ruchira is understanding. Akash is able to understand. Vishwa, Parna, Kanksha, Ruhani. All right, okay. Okay. All right, okay. So, the class 2 profile can be because of a maxillary excess or a mandibular deficiency. Correct? Similarly, a class 3 profile can be because of a mandibular excess or a maxillary deficiency or a combination. It can be a combination also कि थोड़ा सा maxilla भी छोटा है और mandible भी excess है. So it can be a combination of both, giving us these two problems of either a class 2 or a class 3. Okay. Now, if I am a very experienced surgeon, just by looking at the patient, I will be able to tell that, oh, this patient has a class 2 because of skeletal maxillary excess. But if I am new, if I am not so experienced, I will need certain measurements. I will have to do certain measurements on the X-ray to tell whether the maxilla is excess or the mandible is deficient. Okay, because that is where the cephalometric landmarks and all these points, the menton, gnathion, gonion, pogonion, and ANS, PNS, nasion, all these points are there which you have learned in orthodontics, in cephalometrics. We use those points and we make calculations to understand exactly on paper, like how much from the normal the maxilla is forward or backward, and how much from the normal the mandible is forward backward. Okay, so we will do that clinically by clinical assessment of the patient with photographs, and a proper way is to do it on cephalometrics on X-ray, taking a lateral ceph of the patient and analyzing the landmarks and coming to a diagnosis that whether it's a class 2 or class 3. Okay, now this is a very famous envelope of discrepancy. Envelope of discrepancy. Okay, Prof has given this, and I'm sure you've all studied it in your ortho, that there are 3 methods of correcting the discrepancy of teeth or jaws. The innermost envelope, which is this yellow envelope, it is the orthodontics alone. That means chota mota problem hai, little 2 mm, 4 mm, little bit of problem is there, and you can correct it just by tooth movement. Okay, how much you can correct it? Maxilla, so this is the final position. So in maxilla you can do a retrusion of 7 mm, you can do an advancement of 2 mm, you can do an upward movement of 5 mm, and you can do a downward movement of 4 mm by orthodontics alone. Similarly in mandible also. If your discrepancy, if your problem, the problem that you have diagnosed on the X-ray, if your problem is more than that, if you need more than 7 mm correction, what will you do? You will use the green envelope. The second envelope of discrepancy, which is the middle envelope, which is orthodontics plus growth modification. That is when the patient has come to you in the growing stage. Okay, before the last pubertal growth spurt, if the patient has come to you in the growing stage, you can take advantage of that growth and give some appliances like headgears and chin cups and all those things, and use the body's growth for an additional movement. Okay, like for example, if you are able to do a 7 mm retrusion by only orthodontics, then using the growth modification you can do it 12 mm. Okay, so additional some advantages there in growing patients where you can use the middle envelope. But if the patient is beyond the growing age, or if the discrepancy is too much, then you will use the outermost envelope, which is the orthognathic surgery. That is, now it is beyond the scope of orthodontics alone. You have to use surgery along with orthodontics. But guys, remember here very importantly, a surgeon cannot do the surgery alone without orthodontics. You can't reach the outer envelope without the inner envelope. Okay, for example, if this is the jaw, okay, now this is a edentulous jaw, but just understand, okay, if this is the jaw of a patient, okay, and I'm going to move the mandible back, can I just do it without taking care of the teeth, and it will cause my bite, which is okay, to become a severe reverse overjet or a severe overjet. So I cannot ignore occlusion. I cannot ignore the teeth and okay, मैं तो surgeon हूँ, मैं तो खाली जॉ को आगे पीछे करूँगा. आई एम अ सर्जन, आई डोंट केयर अबाउट द टीथ, आई विल जस्ट टेक द जॉ फ्रंट एंड बैक. नो, that cannot be done. Even my surgery is going to fail. My stability of surgery depends on many factors, and one of the very important factors is occlusion. So I have to take care of the teeth before I do the surgery for the jaw. Okay, how to do that? We will learn the steps. Okay, so this is the envelope of discrepancy. Depending on the amount of discrepancy, you will choose which strategy or which treatment to be done for the patient. Okay, now just a little magic of orthognathic surgery. I'm going to show you what kind of patients do really need orthognathic surgery. Okay, what kind of patients need orthognathic surgery? So patients with congenital defects, like this poor boy who had cleft lip palate or cleft palate, for example. Okay, congenital defects like cleft palate or hemifacial microsomia or any peri-Robin syndrome, any deformity which is causing the inability of the cleft palate, repaired cleft palate to grow, or half face is small, or peri-Robin mein the mandible is small. So any congenital defects. These are the indications. We are discussing the indications of orthognathic surgery. कब करनी पड़ती है, क्यों करते हैं हम orthognathic surgery, किस टाइप के patients में हमें करनी पड़ती है. Okay, so first indication is patients with congenital defects. For example, you can look at this child. If you look at his lip closely, you will see there is a scar here. Okay, on the filtral column, you can see two scars, or maybe it's a case of operated cleft lip and palate. Now, because of the surgery, his maxilla is not able to grow. You can see there is a maxillary deficiency. The mandible is still grown. The nose is also some defect because cleft also affects the nose. So, he has a kind of a abnormal looking face because of mandibular excess and maxillary shortening. Okay, so he will need an orthognathic surgery. So that's the first indication, congenital defects. Second is trauma. A lot of times because of trauma, some part is missing, some part is lost, or some part is unable to grow. So in trauma cases also, a lot of times we need orthognathic surgeries. Burns cases, when there is contracture, this patient, see, he had grade 3 burns when he was a child. All this region was burnt. So because of burns, what happens? One of the complications of burns is post-burn contracture, PBC. Because of the contracture, the skin got so tight that the mandible is unable to grow. Maxilla is growing, everything is growing, but mandible is not able to grow. And because of that, you can see how much defect he has. He has a bad open bite. He has a mandible which is flared out, all because of the scar, the post-burn contracture scar. Okay, so burn cases, trauma cases, all these cases will need orthognathic surgery if there is a jaw discrepancy. अगर burns यहाँ पे हुआ है तो orthognathic surgery नहीं करनी. Obviously, if there is a hand burn, you will not do an orthognathic surgery. But if it's a trauma on the face which causes growth restriction, definitely you will need orthognathic surgery. Okay, the next indication is ankylosis. We have all seen in TMJ ankylosis because growth stops. If it's a unilateral or a bilateral ankylosis, it will not grow. Whenever it will not grow, mandible will remain small. If it remains small, it becomes a problem with eating, it becomes a problem with swallowing, it becomes a problem with speech, with airway, and opening of mouth is a problem, so brushing is a problem, all problems. So for ankylosis, the only treatment is not just opening the joint. The treatment also includes correction of the mandible. Okay, so ankylosis cases and for cosmetic corrections. Somebody feels that, oh, I want to look a little better, I want my chin to be more defined, I want to look like, some XYZ hero, heroine. So for cosmetic reasons also, we are doing orthognathic surgeries. In burn case, mandible or maxilla, what is unable to grow? Depending on what is burnt. If the burn has happened here and there is a contracture, it is not seen in all kinds of burns. This is just one example that I am giving you. One example which can cause growth restriction. Anything can, even a tumor can cause a tumor where resection. Suppose there is a tumor in the condyle in a 10-year-old child. तो आपको वो ट्यूमर की वजह से condyle, you have to remove the condyle. अब condyle ही नहीं है तो what will grow? There will be asymmetry. One side is growing, other side is not growing. Right? So anything which causes difficulty in growth or it is a congenital growth defect, it will cause problems and it will need orthognathic surgery. In this patient, burns did not happen here. This area is okay. Burns happened in this region. So it caused a scar. Same scar which we have in cleft palate surgery. When we talk about cleft palate, I will tell you how the surgery causes a scar. And the surgery causing scar causes difficulty in maxillary growth. Similarly, this burns, and not a grade 1 burns, a grade 2, grade 3 burns, deep burns, which is including dermis, which is including muscles. A deep burns causes stricture. Stricture means it's like a scar. And it causes inability for the mandible to grow because of the tightness of skin. Okay, our skin is loose. It allows the lower bone to grow. In this patient, the skin is so tight, it is not allowing the mandible to grow. Right? So that is another indication. This patient, no trauma, no scar, no burns, no congenital problems. Just by chance, he has a class 3 mandible. He has a class 3 profile, and just like that, everything is normal. He has no syndrome, nothing. But normally, maybe he took his maxilla from his mother and his mandible from his father. So different genes causing a combination, causing a short maxilla and a protruded mandible. So this is also an indication, cosmetic correction. And it is given him a reverse over jet. Normally maxilla is in front and mandible is behind, like this. Now this patient has this. The mandible is forward and maxilla is behind. So difficulty in chewing. That's a major problem. Difficulty in speech. His tongue will not be able to move normally like yours and mine. So function and aesthetics is the indication. Another girl, no syndrome, no problem. Just that when I smile, there is excessive tooth show and I don't like it. Maybe I will get married few years later and it's not looking good. Okay, so vertical maxillary excess. Too much show of maxilla. Now here we know mandible is also slightly deficient and maxilla is vertically, it is too much. Anterior-posteriorly it is fine. So aise maxilla theek hai, but vertically it is showing too much. Too much maxilla show, calling vertical maxillary excess. So she says, I don't like my tooth show, and orthodontist says that so much intrusion we can't do with the teeth. Another girl with a syndrome, cleft, similar problems because of the syndrome. Another girl, hemifacial microsomia, you can see the ear tags, small deficient mandible. Okay, so these are all the indications why we are doing the orthognathic surgery. Okay, and just showing you some results, how the person face changes immediately after surgery. This is the girl who had vertical maxillary excess. This was her profile before surgery, and this is her profile after surgery. Can you see the amount of confidence that this girl will have when she goes to school, looking from here to here? This is not even a full post-op. This is still, she has some lip swelling and maybe just a 2-week follow-up. But you know, it is a very drastic change. And orthognathic surgery is one surgery where even the surgeon, you know, feels godly. Oh, आज तो मैंने मतलब भगवान वाला काम कर दिया है. And I have changed the person's personality, looks drastically. Alright, there's nothing like God because we are nowhere close to even the feet of God, but it's a drastic change. You can see this boy, his name was Kshitij. He has a severe class 3 mandible, and just by a simple orthognathic surgery, the mandible was taken back and absolutely straight profile. Can you guys appreciate these changes? These pre-post clinical changes? Can you all understand? So this is the magic of orthognathic surgery. If planned correctly, if executed correctly, it gives excellent results in a few hours of time. Alright, so this has to be done planning way. Yeah, these are all cases not done by me alone. These are all institute cases done when I was a PG or an SR. Okay, my cases, they are still copyrighted and I have not released some of them. Some of my cases also I will be showing you. Yeah, but these few patients are all from MAMC. Okay, alright. So how do you do an orthognathic surgery? Can you just start doing surgery? Aaj patient chal ke aaya and I will start doing surgery? No. There are certain steps which you have to do. The first step is pre-surgical orthodontics. Like I said, you cannot just move the jaws by ignoring the teeth. whatever compensation. So whenever God has given you a face like this, okay, God will always want, or nature, I will not say God, but nature will always want the teeth to touch. Then only the patient will able to bite. Okay, the teeth should touch, right? If it is a class 2, then mandibular teeth will also flare and they will try to touch the maxillary teeth. If it is a class 2 div 2, the mandibular teeth will also be retruded and they will try to touch the maxillary teeth. So always, before the patient undergoes a surgery, the teeth are touching each other. Okay, what we have to do is, we have to decompensate whatever compensation nature has done. Pehle you have to decompensate. You have to bring the teeth to proper alignment. It will worsen the orthodontics. It will worsen the looks of the patient. But you have to do it, because only in a corrected occlusion you will do a surgery. Okay, so you will do the pre-surgical orthodontics for decompensation of occlusion. Compensation means what nature has done. Nature has done some jugaad. What do you call jugaad in English? I don't know. Some tricks nature has done to make the teeth touch. Okay, but that is not the right way the teeth should meet. They should meet like this. So first you will decompensate the compensation done by nature. You will bring the teeth to proper alignment. Here there is one question which is asked again and again as a doubt, which is a repeated question in NEET. Which of these is a prerequisite for orthodontic surgery? Angles class 1 occlusion. When I say pre-surgical orthodontics, it doesn't mean that every case needs to be brought to an angles class 1 occlusion. No, I don't need a class 1 occlusion. I need a good cusp to fossa relationship. I do not need an angles class 1 occlusion. It can be angles. See, what is angles class? Angles class is a molar classification. Okay, and as a surgeon, it is absolutely not important whether it is molar class 1, molar class 2 or molar class 3. It can be any molars class. It can be any angles classification. The only requirement is it should have a good cusp fossa relationship. The upper and the lower teeth should intermingle properly. Needn't be class 1. It can be class 1, it can be class 2, it can even be class 3, because when I move my jaw, it should settle in a good cusp fossa relationship. Okay, so angles class 1 is not a compulsion. Okay, naturally if you are getting angles class 1, very good, but it is not compulsory. You can settle the occlusion in class 2, class 3 as long as it is giving a good cusp fossa relationship. That the orthodontist will decide कि मुझे class 1 बनाना है, class 2, class 3. That is the orthodontics decision. All a surgeon needs is a good cusp fossa relationship. So first step is pre-surgical orthodontics. Second step is your assessments and analysis. Okay, so these are all done on X-rays, and we do it on lateral cephalograms and PS cephalograms. So it is called cephalometric analysis. Why cephalometric? Ceph means cephalo, head region. Metric means everything is measured. It is metered. The X-ray, that the plain PA skull that you do, it does not have any scale. It does not have any measurement. But when the same X-ray you do it with cephalometrics, there is a scale with it. If you have ever seen a lateral ceph or a PA ceph, there is always a scale with it. It is always measured. That is why it is called cephalometric analysis. There is no, enlargement or zooming in, zooming out. No, it is a metered, measured analysis. So all the cephalometric analysis we always do on a cephalogram. Okay, it can be a lateral cephalogram and a PA cephalogram if required. We will discuss how we do everything. So the second step is you assess, you analyze the X-rays, how much movement is needed. Third step is you do a mock surgery. Means before doing the actual surgery, you do the surgery in a model. Okay, you will take the impression of the patient, you will make a cast out of it, you will articulate that cast on an articulator using phasebow transfer. On the articulator, you will do the cuts, you will do the surgery, and when you do the surgery on the articulator, you do the movements. I have to take my maxilla 4 mm forward, I have to take my mandible 5 mm back. Whatever surgery you have done, what you do? You take an impression of the final position of teeth. That is called a splint. A surgical splint or a surgical wafer. So the purpose of mock surgery is to make a surgical splint or a surgical wafer, so that when you do the actual surgery, the splint or the wafer should fix in that position. जो आपने पहले से सोचा, you have decided that okay, that much I have to do. So now wherever my splint is fitting, that is the right position in OT. So that will help you to guide the surgery. So the mock surgery is done. It can be done on a cast, and nowadays it is done digitally. Like everything is done digitally now. Now mock surgeries are also done digitally. I'll show you how it is done. Next step is the actual surgery, which you will do depending on maxillary surgery or mandibular surgery, what kind of surgery you want to do. And the last step is post-surgical orthodontic settling. Okay, so you have done some orthodontics, now you have done the surgery. After surgery, some 0.1, 0.2 millimeters, some minimal cusp fossa relationships you have to do. That last few millimeters of settling you do again with orthodontics. Okay, so these are the 5 steps of a conventional orthognathic surgery. Okay, these are the 5 steps of a conventional orthognathic surgery. Now some patients, their occlusion is not very bad and the surgery which they need is very minor. Okay, the occlusion is not so bad, the surgery that you need is very minor, and the pre-surgical orthodontics, usually we know that it takes around 1 to 2 years, because orthodontics is a long treatment. You will put braces and you will put wires, and in few millimeter by millimeter the teeth will move. So this is a long treatment. It's a 1 year, 6 months, 8 months, depending on the type of malocclusion. It is a long treatment. So sometimes when the malocclusion is not so severe and when the surgery is also not that severe, not that major, what you do is you do a surgery first approach. You do a surgery first approach. Okay, so it can be done in 2 ways. It can be done like a conventional orthognathic surgery. Mind you, 95% patients we are doing conventional orthognathic surgery. Only 5% or maybe even less, very few patients, just less than 5% patients we are doing the surgery first approach. In surgery first approach, we skip step 1. Because the occlusion is not so bad, because the major orthodontics is not required, we skip the step 1. We directly jump to step 2, 3, 4, and whatever orthodontics is required, we do it in the end. Okay? But it is done for very, very simple cases, very, very minor cases, very, very few indications which we will see in the end. Normally, majority of the patients undergoing orthognathic surgery have to follow the 5 steps: conventional pre-surgical, assessment, mock surgery, surgery, and post-surgical orthodontics. Alright? Are you all with me here? Yes, nowadays it is all done digitally, Sunanda. Mock surgery, repeat. I will show you the mock surgery. Don't worry, I'm going to show you. Wafer in mock surgery, I will show you the wafer. In the end of orthognathic surgery, we have class 1 of any of the class. Any of the class. You can have any. See, this class that we are talking about is a molar occlusion. Right? We are talking about surgery, dude. In surgery, we don't care about molar occlusion. We care about good teeth relationship. Whether it is class 1 molar, class 2 molar, class 3 molar, all are correct. All are fine with the surgeon. All are fine with the patient. So any occlusion you can have. It is not a compulsion to have a class 1 occlusion. Okay? Alright. So I'm not going to talk about step 1, which is the orthodontics, which Dr. Kunal is going to speak to you in the ortho lectures. We will start with assessment and analysis. Okay. Now, every patient who is undergoing orthognathic surgery, first we will take photographs. Okay, otherwise how will I show my students that what is right and what is wrong? So we will take photographs and we will analyze the photographs. Okay, she has a vertical maxillary excess, she needs this, she needs that. Then you will do lateral ceph, PA ceph. Okay, you can see that it is a metered cephalometric x-ray, and if you watch closely, I think there is some excess whitening, but you can see the soft tissue outline also, and OPG. Okay, these three x-rays usually we start with, and we do analysis. Now you have to remember the name of two analyses. Okay, first is COGS analysis. Okay, what is COGS? COGS means cephalometrics for orthognathic surgery. COGS, C is cephalometrics, for OGS is orthognathic surgery. Okay, COGS is always done on a lateral ceph, and it is done in all patients. Whichever patient needs orthognathic surgery, in all patients we have to do COGS analysis. COGS analysis is always done on a lateral cephalogram. Okay, next is PSF. PSF pe we do something called as Grumman's analysis. Okay, do we do it in all the cases? No, we don't do Grumman's analysis in all the cases. We do it only in the cases of asymmetry. Please remember this fact. Whenever the orthognathic surgery requires correction of asymmetry, if the mandible is small but it is in midline, you just have to bring it forward. But if the mandible is small and teda, okay, if there is asymmetry, one side is normal, one side is chota. If there is asymmetry, then you have to correct the asymmetry also. So for that, you have to do a special analysis along with COGS. COGS to karna hi hai. COGS you have to do in all. But along with COGS, you also have to do a Grumman's analysis, which is always done on a PA ceph. Okay, see, if you see closely, this is the central midline, this is the nasal midline. There is some whitening here, I don't know why. This is the maxillary midline, and this is the mandibular midline. So if I trace it like this, you will see that there is a discrepancy in the midline. The mandible is shifted to one side. That I am not able to appreciate on a lateral ceph. That I will be able to appreciate only on a PSF, right? PSF mein dikhega, lateral mein to dikhega nahi. So whenever there is an asymmetry, remember this word will be there in exam. Whenever there is asymmetry, one extra analysis you have to do, which is the Grumman's analysis, which is always done on a PA ceph. It cannot be done on a lateral ceph. Some landmarks are different. If you take those landmarks and you have to calculate how much is the asymmetry. Accordingly, you will do the surgery. Okay, now you have done all the tracings and all the measurements and everything. Now you have decided that, okay, in this girl, I'm just taking the example of this particular girl just for an example. Okay, so this girl has excess vertical growth of maxilla. Now I have done my analysis. Now I have taken her impressions. I have taken a Facebook transfer. I have transferred her cast. Okay, this is the maxillary cast. This is the mandibular cast. I have transferred it on an articulator. Now on the articulator, I am going to actually do the surgery. Okay, I am going to cut the maxilla. I mean the cast. Okay, here I am going to cut the cast. I am going to cut the maxilla 4 mm to take it back. I am going to cut it 4 mm on the top like this. And I am going to take the maxilla up. Okay, now when you take the maxilla up, because the condyle is here, the condyle will rotate. The mandible will auto-rotate with the maxilla. And if I have to do a bi-jaw surgery, I will do the same surgery on mandible also. So whatever surgery I have to do, I will do it on the cast. Okay, this is known as mock surgery. I will show you images of the mock surgery. So after I have done this, all this lateral ceph, COGS analysis on lateral ceph, Grumman's analysis on PSF. Okay, I have done all these analysis. Now I am doing my mock surgery. Okay, I have taken the maxilla. Now I am going to cut the maxilla 4 mm. Okay, because bahar se bhi katega, andar palatal side se bhi you will cut it. Okay, then vertically you will cut it. Whatever surgery you have to do, you will do. Then you will bring the maxilla up. Okay, so as residents, we are always garib. Okay, we don't have any fancy things in government hospital. So we used to stick it with wax. So just stick it with wax. Okay, now many better things are available. Now we don't do it on cast anymore. We do everything digitally. But back then when I was a resident, and still questions are asked, so I'm showing you this. So you stick it. Okay, Now the final position, matlab, when you do the surgery, this will be the final position of maxilla. Now how will I record this position? I have to record this position. I have to take this record position in the OT. How will I take it? What I will do? I will make an impression. I will make an acrylic impression of the occlusion. Okay, what will I do? I will just take an impression of the occlusion, the bite which you take. Okay, you know how to take a bite, a wax bite or an aloo wax bite. Just like that, I will take a bite of this cast, and that bite, a paper thin bite, is known as an occlusal wafer. Why do you call it a wafer? Because wafer is very thin. It can just fracture, right? Wafer means chips. जो हम chips खाते हैं, Lays and all these uncle chips. They are wafers because they are very, very thin. Just like that, the occlusal guide that you make, or the occlusal wafer or splint, these are the different names. It is very, very thin. It is paper thin at the occlusion. But if I make it very thin, it will fracture. So the borders I make thick. I make the borders thick so that वो टूटे नहीं. And the occlusion, at the occlusion, it is paper thin. Okay, because of occlusion, मेरा measurement change नहीं होना चाहिए. So it is wafer thin. You can see it is even perforated at one point. So it is wafer thin. That is why it is known as an occlusal wafer or an occlusal splint. Now this occlusal splint, I will put it in the Sidex. I will put it in the chemical sterilization because obviously I can't autoclave an acrylic thing. I will put it in, no, you don't have to study about these analysis in detail. Just know their names. Okay. Yes, photographs, Ruhani, they are done at all stages, before decompensation, after surgery. So we keep taking photos all the time. Okay. So this splint, I am going to chemically autoclave, chemically sterilize and take it to my patient. So when I am doing the actual surgery, I will put that splint. कि teeth ऐसी position पे मिलने चाहिए. If the teeth are meeting in this position, that means my advancement, my setback, my surgery is correct. So this will be a guide to my surgery. Okay. Nowadays, like I told you, we are doing everything digitally. I am not taking any impressions. I am not putting any cast. Using the patient's CT scan. We use the patient's CT data. We feed it to the computer. And all these mock surgeries, you can do it in the computer. Rather, you can even show the patient that, now you're looking like this, like a class 3 person. And after surgery, when we take your mandible back, you will look like this, a class 1 person. So everything is now done digitally. That is why it is known as VTO, Virtual Treatment Plan. Yeah, Virtual Treatment Operations. Okay, so virtually we do everything, and this splint is also 3D printed now. Okay, what is 3D printing? 3D printing जो हम computer से directly print कर सकते हैं. You can directly produce that thing through a computer. You will learn about it in ortho and prostho. So you can 3D print the splint. You don't need to actually take all these casts and impressions. Everything is done using CT scans on the computer digitally. So this is how earlier we used to do a virtual treatment planning, and this is how now we do a virtual treatment planning. Okay, now we come to actual surgery. Okay, how will we do the actual surgery? Now everything is planned, the splint is made. Now we will do the actual surgery. What do we need for the surgery? We can use many cutting instruments. We have to cut the bone. After all, you have to cut the maxilla, right? If I'm taking my Shivu, so you have to cut the mandible, you have to cut the maxilla here. It's not easy to cut, right? So you need special instruments. So you can use an oscillating saw. These are all there in your notes. Okay, so anybody who is writing down fast, please don't write anything. Just focus on understanding. All these images are there in your notes. All these things which I'm telling you are there in your notes. Just understand what I'm saying. Don't scribble, don't write. You will not be able to understand. Okay, so just understand now. This instrument is an oscillating saw, which is used to cut mandible, cut maxilla, cut bone. Okay, but it's a dangerous instrument. It can damage the soft tissues also. So to come over it, we have started using the piezoelectric saw. The piezoelectric inserts. Okay, these tips are known as inserts. These, just like those scalar tips, you have a pointed tip, you have a flat tip, just like a scalar. Similarly, in the piezo also, we have different types of tips. And these tips are known as inserts. Okay, you insert it into a handpiece, and even if you put the tip on a soft tissue, it will not cut the soft tissue. That is the beauty of piezoelectric. It will only cut hard tissue. It will never ever cut the soft tissues. So if by chance your hand slips, the surgeon hand slips, and it touches the soft tissue, it will not damage it. It will not damage the nerve, it will not damage the mucosa. No soft tissue will be damaged. So that is the biggest advantage of piezoelectric. What is the advantage? Biggest advantage, no damage to soft tissues. Okay. Small disadvantages. Disadvantages are small. It's expensive. Saw and burr are cheap. This is a little expensive and it is slow. Okay. Surgeons are usually impatient people. उनको सब कुछ fast चाहिए. तो वो कहते हैं छोड़ो छोड़ो सौ लो ब्रर काट दो. So surgeons are impatient people. So sometimes, I mean not every surgeon, there are good surgeons who are patient. So it is slow. It is too slow. It cuts very, very slowly. Okay. So that is a small disadvantage of piezoelectric, that it is an expensive instrument and it is slow in cutting as compared to a saw or a burr. But these disadvantages are very small. Very big advantage is that there is no damage to soft tissues. Okay. Thirdly, we can use the conventional burr, the micromotor burr and micromotor handpiece that we use for third molar disimpactions. Same handpiece and burr we can use for cutting the bone also. Okay, so these are the three instruments. Other than that, these are cutting instruments. Okay, other than that, there are a lot of special instruments for each surgery. As I tell you each surgery, I will be telling you about these instruments also. Okay, so with this we complete the conventional orthognathic surgery steps, starting from pre-surgical orthodontics to analysis, planning, then mock surgery, making a wafer or a splint, actually doing the surgery using all these cutting instruments, and then doing a post-surgical orthodontics. Okay, are you all with me here? सबको समझ में आ रहा है? All able to understand? Because now we are going to start something really, really interesting. We are going to start with the mandibular surgeries. Okay, just give me a thumbs up अगर सबको समझ में आ रहा है. There's a little lag between this and this. So, okay, very good, very good. Most of you are understanding. All right, very good. Okay, so just remember one thing, guys. For a dental surgeon, mandible is a pain in the, okay, whether it is trauma, whether it is orthognathic surgery, whether it is pathology, the mandible is a painful bone. Okay, not literally, but सारा confusion, सारा complication, सारी planning is required in mandible only. All the other facial bones, fracture treatment, very easy. Orthognathic surgery, very easy. But when it comes to mandible, it is too complicated. Why? Because I am taking my Ramu here to show you, because it is a mobile bone. Okay, whatever surgery you perform on the mandible, you perform the surgery in a static bone, in a bone which is not moving. But when the surgery is over and when the patient is out of the general anesthetic, this bone is going to move, and the muscles, the connective tissue, the ligaments, everything that is attached to the mandible is trying to worsen your surgery, is trying to, relapse your surgery. So mandible, all the surgeries in the mandible have to be really planned carefully so that in dynamic function, during function, your surgical outcome should not reverse. Okay. Similarly, when we talk about orthognathic surgeries in the mandible, there are certain landmarks which you have to be careful about. Okay, first is the inferior alveolar nerve. Okay, you all know that if this is the mandible, there is a tongue shaped lingua. Lingua means tongue. So lingula, there is a lingula, which is this, if you can see here in this, I've taken a real mandible here to show you guys. This tongue shaped depression, can you see this tongue shaped protuberance? और उसके पीछे गड्ढा है, there is a hole behind it. So this is the lingula. Okay, from the lingula, the mandibular nerve gives the last terminal branch, which is the inferior alveolar nerve, and it goes and runs throughout the mandible, and then in the end it comes out of this foramen, which is the mental foramen. Okay, so from here, from here to here, throughout the mandible, there is a nerve which you have to take care of, which is the inferior alveolar nerve. Then there is a mental nerve. When we are doing a surgery in the body region of the mandible, the mental nerve will always be there to harass you. Then there are teeth. If you do the surgery very close to the teeth, okay, suppose I am doing my cut, osteotomy is doing here. What I am going to do? I am going to damage my teeth, the roots of the teeth. Or if I am just 1 mm away from the teeth, I am going to damage the blood supply to the teeth, the incisive, final terminal incisive branches which supply the teeth. So I am going to devitalize my teeth. मैंने उनकी blood supply काट दी ना osteotomy में. So I have to take care of the teeth, their blood supply, the incisive branches. I have to take care of the muscles, major bulky muscles, the masseter, the medial pterygoid, lateral pterygoid, temporalis, यहाँ पर either mentalis, the hyoid muscles, the suprahyoid muscles, geniohyoid, all these muscles which are there on the mandible, I have to take care of that. Very importantly, pterygo masseteric sling. This is a very, very difficult structure to negotiate when you are doing mandibular orthognathic surgery. So we know that the muscle which is attached on the lateral border of mandible is the masseter. The muscle, same direction, the muscle which is there on the inner side is medial pterygoid. So pterygo masseteric, medial pterygoid, masseter. These both muscles at the angle of mandible here below in this region. So medial side pe medial pterygoid, lateral side pe masseter, and in the lower border of mandible they join hands. तू मेरा भाई मैं तेरा भाई, यहाँ से masseter आई, अंदर की साइड से medial pterygoid आई, and in the lower border they form a very, very tight ligament which is known as the pterygomasseteric sling. Now the surgeon is fully confident that I am next to God, I am going to do a BSSO, I am going to put my mandible 5 mm back. And the pterygomasseteric sling will say, Acha, when the GA effect goes away, I am going to throw the mandible out because the sling is so tight, it is so firm that any movement, if you have not done it carefully, it is going to, in spite of the fact that you have put screws and everything, plates, it will cause a relapse in your surgery. So in mandible, there are a lot of structures which decide the success of your surgery, which decide, you know, how much possibility is there, how much setback you can do, how much advancement you can do. It is very, very decided. You have to be very careful in mandible. Okay? Whereas in maxilla, बस दांत का ध्यान रख लेंगे. Only teeth. Just have to take care that don't cut near the teeth so that the teeth should not be devitalized. The only structure in maxilla that you have to be careful about is the teeth. Okay, whereas in mandible, lot of structures. Okay, so whenever you are planning any surgery, these are a lot of things which decide the stability of the surgery. We will talk about stability in the end. So basically, you have 6 types of mandibular surgeries. This table is there in the notes. Just mug up the table. It will be very easy to mug up the table if you understand it now. Okay? Understand this now, so you don't have to mug it up. You will understand everything. Okay? Before we begin with the surgeries, if this is the mandible, and suppose I am cutting the mandible here. I have to take the mandible, suppose I have to take the mandible back. Okay? So I am cutting the mandible into 2 pieces. Okay, I am taking my eraser. This is my osteotomy. I am cutting my mandible, and now my mandible is in. It's in 2 pieces. Okay, I can take it forward, I can take it backward, whatever I want to do. Now there is a term which is known as. अरे यार ये इधर क्यों नहीं आ रहा है? 1 second. There is a term which is known as proximal, and there is a term which is known as distal. Basically, it is pure first year anatomy, okay? Anatomical position, what is proximal, distal, medial, lateral. So anything which is close to the midline is known as proximal, okay? So when we do the mandibular surgeries, the part which has the condyle and the joint, okay, obviously that part is closer to the midline, okay, the part which has the TM joint and the part which has the condyle and joint, that part is always known as the proximal segment, okay. These terminologies are again for the mandible, they are not for the maxilla, only for the mandible. Lot of times these words will come in the exam, lot of times these words will come in the notes, in the questions. You have to understand. Proximal means the part which has the joint, which has the condyle, which is closer to the midline. And distal means the part which is away from midline. Okay, that means the part which has teeth and the part which has the nerve. Okay, the part which has the teeth and the part which has the nerve. It is the distal part. Okay, it is a rule. There is a rule in mandible that the nerve should always lie in the distal part. The teeth carrying segment is the distal segment, whereas the joint carrying segment is the proximal segment. Okay, now in the lecture also I am going to use these words proximal, distal again and again. So everybody understood na what is proximal and distal? Niharika, don't worry about the PTM. I am going to tell you about pterygomaxillary sling when we talk about BSSO. Again I will be telling you. So don't worry if you have not understood. Okay, proximal and distal. Proximal, the one which has joint. Distal, the one which has nerve and teeth. So there is an MCQ in NEET which says which part of the osteotomized mandible carries the nerve. Proximal part, distal part, it can be any or it can be none. So answer is distal part. Nerve always in the distal segment. Teeth always in the distal segment, and joint always in the proximal segment. Okay. So with this we begin with the 5 or 6 surgeries which we do in the mandible. VRO. We will begin with VRO, which is the simplest surgery. Inverted C, inverted L, which is a modification of VRO. BSSO, which is also a modification of VRO. Body segmental surgery, subapical surgery, and genioplasty. Okay. Let us take a small break, guys. I hope you have all understood. Till now, we have discussed the basic concepts of orthognathic surgery. We have covered all the basics. Okay. Now we will go for each surgery, and if there is any doubt before the break, you can take the doubt note. Manarishi, distal is away from the midline. Distal is away from the midline. Proximal is close to the midline. Okay, proximal means proximity. Proximity मतलब नजदीक. The body के नजदीक है, joint के नजदीक है means proximal. Distal means दूर. Distal से याद रखो दूर. Proximal से पास रखो नजदीक. So whatever is far away is distal. So the segment which is away from the joint, which is away from the midline, which carries the teeth, is the distal segment. Alright. So here we will take a small break. Okay, after the break, we will come and discuss individual surgeries of maxilla and mandible and the complications which happen. Okay, after this is the end of the class on YouTube. We will continue with the class on the Class Plus on the MDS Live app. Okay, any doubts? Anybody? You can ask me your doubts before we take this small 10 minutes break. Just 10 minutes break. There is 1 minute to 7. We will start the break at 7 p.m. and we will meet again at 7:10 sharp. Yes, after break we will continue on the app. Alright. Okay. So if there is no doubt, then we'll finish the session here. Thank you so much all the non-DBMCI students who are there with us in the YouTube session. I hope you've understood, you've liked the class. And all the other students who are the DBMCI students, you can continue the class on the app. It's 7 o'clock sharp. We take an absolute 10 minutes break and we meet at 7:10 p.m. on the app. Okay? Just have some tea, coffee. Just 10 minutes break. Okay? Sakshi, just a 10 minutes break.